Hi, good afternoon. My name is Sonia Moreno Rogers. I'm with Nurses Care Hub, and next to me I have Dr. Erin Bettis. She is a DNP, APRN, AMPC, AGNPC, and ACHPN. I know that's a lot of credentials, but I wanted to introduce Dr. Bettis today. She is going to help moderate today's Nurses Unite, providing care for a changing America. I hope all of y'all are doing super today, because today is Super Sunday and we have amazing speakers for you this afternoon. And I also, before we get started, want to thank you for joining us today and registering to be part of this amazing series. Before we get started, I also want to thank our sponsor, Halo Branded Solutions, for these item giveaways that we have sitting on our desk.
Yep.
So for those of you who are participating today, you have a chance to receive a bag full of amazing goodies that are inside. And we just want to thank Halo Branded Solutions for supporting Nurses Care Hub and nurses all over the world. So we are happy that you are here today with us. And so I want to get started, and I want to introduce Dr. Adelita Cantu, and I also want to introduce Dr. Latricia Harrison. And I want to let them tell us a little bit about themselves before we jump into their presentation, which I know you are going to enjoy. Erin, would you like to do the honors and introduce both the speakers today?
I would. So Dr. Adelita Cantu is a PhD registered nurse. She's also a fan, and she's in San Antonio. She is faculty. She has done a number of things for the nursing profession as well as her community. And I will not belabor the point, but Dr. Cantu is a mover and a shaker, as well as Dr. Latricia Harrison. She is a DNP, an advanced practice nurse, and a family nurse practitioner who is also another nurse rock star. So we've got a huge lineup today as well as in January. So I hope our viewers will remember to join us in January 9th for some more powerhouse nurses. But Dr. Cantu and Dr. Harrison, I'm going to ask Dr. Cantu, since you're our speaking first, if you can give us a little bit of a brief bio. I know you've got a lot of things that you have done over the years for the profession and the community and the nation, but can you share with us a little bit about your background?
Yes, good afternoon, everyone. I'm saying good afternoon because it is afternoon here in San Antonio, Texas. So good afternoon. My name is Adelita Cantu, and I am a native San Antonian. I have been a nurse for over 40 years. I just say over 40, not how much, but over 40. And my expertise is in public health nursing. I've been a public health nurse all those years. Currently, I'm an associate professor at the University of Texas Health Science Center School of Nursing. And I do several things there. I do teach in the undergraduate as well as graduate program, and do a lot of community projects. We are currently partnering with our Metro Health to do pop-up vaccine clinics, COVID vaccine clinics in the community. So that is a current thing I'm doing. But I also teach population health, public health nursing for the undergraduate students, and I'll have an opportunity to do those things that I teach with them.
Thank you so much, Dr. Cantu. And Dr. Harrison, can you share with us a little bit about yourself?
Good afternoon. Hi, I'm Dr. Latricia Harrison, and I am a family practice nurse practitioner, as Dr. Perez said. I have been working as a family nurse practitioner for 17 years, and I've been a nurse, a registered nurse, for 27 years. I own and operate a nurse practitioner run clinic in Houston, Texas, where I see the indigent population. I also am a clinical faculty for the University of Texas Health Science Center and University of Texas Medical Branch. And so right now I'm currently affiliated with the National Black Nurse Practitioner Association, where I'm a founding member. And I'm also a member of the board of directors for Texas Nurse Practitioner Association.
Well, thank you both. It's incredible to hear a very brief bio, but very relevant, meaningful, and impactful to our viewers, our profession, and our community. And so I will let Sonia, if you want to, let's dive into our wonderful day.
Yes, we are honored to have you both here with us today. So thank you very much for your introduction and your bio. Nurses Care Hub sought out some amazing leaders because we designed this webinar series to be based on nursing topics from the Future of Nursing 2030 report. And so today we want to start with our first presentation by Dr. Cantu, and it's nursing in the global community, how our nurses and medical providers addressing migrant population health needs and the healthcare workers that serve them. Dr. Cantu will begin her presentation, and thereafter we will have a discussion with several questions that stem from the Future of Nursing 2030 report. So Dr. Cantu, would you please begin with your presentation and share with the audience all this great information?
Yes, certainly. I'll put up the slides. Yes. Again, good afternoon. And health and healthcare, and what we're doing, particularly myself and students, and how to be a global citizen by understanding migrant and refugee healthcare. Next slide, please. I always my students is just, do you understand the topics that we're talking about? But migrants are something that's about not only in health professions, but just globally. So we started by migrating as an adjective, especially of people where they're migratory, they're moving on the move. But we use it as a noun a lot, a person or an animal that migrates, a person that is migrating, a person who has to permanently relocate to a new country, but who may be subject also to removal by the government. We also do have migrant farm workers, so people within the country that move, that are what we consider seasonal workers. They also have a unique healthcare needs as well as populations. Next slide. So just some statistics here that I thought was really important to just kind of frame it for all of us. 2020, 281 million people were living outside their country of origin, and up to 173 million in 2010. But international immigrants represent about 3.6% of the world's population. It's fairly significant in just 20 countries. The USA, of course, remains a large destination for migration. We host 51 million international migrants, and that was last year in 2020. And that's equal to 18 total. But actually, Germany hosted the second largest at around 16 million, followed by Saudi Arabia, the Russian Federation, and United Kingdom. So in America, sometimes we see this as a new United States, but it is not. People are migrating all over the world. India topped the list in 2020 with 18 million from India living outside their country of birth. Other countries with a large transnational community include Mexico, of course, Russian Federation, China, and Syria. Largest number of international migrants in 2020 resided in Europe, not here in America, but in Europe, with a total of 87 million. Northern America hosted the largest with 59 million. Northern Asia followed. So again, just to looking at these numbers, and it's important, and I always talk to the students too, it's important to understand the perceptions and the things that are going on around the world. You want to be a global citizen. It's not just happening here in the United States. It's a global issue that demands that we treat it a global perspective, not a local perspective. Next, please. Now, this one I always, I'm on in terms of talking to students about countries, different countries. Actually, women that migrate are actually catalysts for change. They promote positive social, cultural, and political norms within their and throughout the communities they go to. Nearly half of all international migrants were women or girls. And I just want to highlight, this is really, really important. When we look at structural changes that need to occur in various countries, women have been a spearheading that. So in fact, when migrant populations come into a country, investing in women, spending money in educating, investing in those resources that can reach their potential actually does a very positive catalyst for change for the whole country. So that's always key. Again, we don't always think about it, but if we think about it from a global perspective, women and the roles women play, as we can see here with this seminar series that you're doing, women are a catalyst for change. International migrants often make up a larger proportion of the working age persons compared to the national population. So I have 2 bullets in here that really look at the dependency ratio. I spend time talking with students about what that dependency ratio is. So if you have more, a lot more younger people under the age of 5 and older people over the age of 16, over at the age of 65, you need to have a good proportion of a working age population to be able to support them. So that's what we call the dependency ratio. So in fact, international migrants make up a large proportion of that working age population. So in turn, again, we need that population there to support the population that is dependent, our younger population, our older population. So another positive thing about international migrants and what they can offer to any particular country. Next slide, please. Okay, so health needs, not too unusual in terms of health needs of vulnerable populations, because certainly this population is vulnerable, particularly when first entering a country. The most frequent health problems of newly arrived refugees and migrants include accidental injuries, hypothermia, burns, GI issues, cardiovascular events, pregnancy and delivery related complications, diabetes, and hypertension. So those last few, cardiovascular events, diabetes, hypertensions, are not definitely unusual than what we're seeing here with our population in our communities. But some of the unique things happen because of the traveling they did. These accidental injuries, hypothermia, burns could have occurred while they were trying to migrate. So those could be some unique needs that they have. Female refugees, migrants frequently face specific challenges, particularly with reproductive health, maternal, newborn, child health, sexual and reproductive health, and violence. Not only violence in the country that they left, but also some of the violence they may experience because of their vulnerability when they're in the country that they're trying to get to. And then there's a health risk associated with population movements, psychosocial disorders. Again, the anxiety and the stress of leaving origin and then coming somewhere where you don't know the language, you don't know the culture, you don't know where you're going to necessarily be sheltering. Think about all the psychosocial disorders that can come from that. Reproductive health issues, as I said before, there's higher newborn mortality. Much of that is associated with the migration. So there's a fragmentation of prenatal care, but also nutrition. And that has a part to play in newborn mortality. Alcoholism, substance abuse, and then exposure to increased violence. And the increased violence not only causes stress if you're the victim of that, but just your exposure to that. Particularly with children, the more adverse childhood events they have, the more term consequences they'll have as they grow into adulthood. And there's an increased, all of that increased their vulnerability to these medical diseases like cardiovascular events, diabetes, and hypertension. Now, the issue regarding to the non-communicable diseases is the fragmentation of care. If I was receiving care for diabetes where I was, then I had to move to another country. That fragmentation of care contributes to the severity of these non-communicable diseases. Next slide, please. With health needs, you need to dispel. Right now, there is no systematic association between migration and the importation of communicable diseases. Right now, particularly in the political dialogue right now with COVID, there's a lot of discussion and conversations in the media about this population introducing communicable disease, but there is actually no systemic information association with that. The communicable diseases that are associated with poverty are what we're seeing also the migrant population who lives in poverty. But tuberculosis is a problem with people who live in poverty and low income, HIV and particularly influenza. The WHO, the World Health Organization, does not recommend obligatory screening for diseases as someone enters the country, as it may cause unnecessary anxiety. Rather, they can be offered for both communicable diseases as well as non-communicable diseases. So rather than saying someone has to pass a particular health screening assessment when they enter, which can cause unnecessary anxiety, that is something to be considered and to be offered, and let that person make a decision about that. Next slide, please. As healthcare professionals, how do we help the professionals, the growing professionals, understand what it means to be a global citizen? And the first thing I always talk about with our nursing students is building that trust relationship. That is the first thing. You want to concentrate on not getting to the end goal of your relationship, but the goal of building that trusting relationship, so therefore they can be a partner with that healthcare encounter. And primary goal, we have a nurse practitioner who will be coming up and talking and really focus on primary care, same with the population, primary care. And then after that is cultural understanding, the development of cultural competence. And this is through development of an attitude, a knowledge base, and a skill base that allows you to care for a population that is different from your own. That is key, is how do we think about understanding attitude, knowledge, and skills that will help us in terms of cultural understanding and cultural competency, so I can better provide care to a migrant or refugee population. Understand there's always going to be communication barriers, language barriers. How do we go about using interpreters? There's a lot of services right now that you can as you're talking to an individual, as you want to talk to them, you can use a phone. I've operated with an organization called Vital Signs. We call them and they bring in an interpreter. You now can do that on your phone, where that person will speak into your phone and the phone will translate it for you. So there's a lot of facilitators now when a barrier does present itself, and we need to take advantage of those when we're providing care to a population that speaks another language. And then understand the health and social conditions of the country of origin. Remember that many of them are coming from countries that are in civil conflict. There is civil war, so there's been exposure to violence, but there's also from countries where it's very low income. And so a lot of poverty situations, vulnerability situations. So like here in San Antonio now, we've received quite a number of Afghan population, people coming from Afghanistan. So we talk to our students about understanding what's going on in Afghanistan and why people are in that time, that country. And then time. People have different perception of time based on the culture where they come from. I know I'm from a very traditional Hispanic population, and we do value our past and very present orientated, not necessarily at times future oriented. So that can have that can cause some conflict within that encounter, because it's a population coming from a country where they weren't operating by appointments, appointment to see the physician or appointment to see the provider. And so this is new. And so it does create an opportunity for both parties to learn, the healthcare provider as well as the person. And then healthcare systems, understand what the healthcare system from their country. Was there a healthcare system in their country? Did they have primary care? So understanding those structures within their healthcare system will help us deliver better care to this population. Next slide, Okay, and this is my last slide, but I do want to introduce this simulation. One of the ways that we as a team work with our students to understand where people are coming from, build those attitudes, skills, and knowledge is through simulation. Doctors Without Borders, I was fortunate enough in 2018 to go through a 1-hour guide that they sponsored, which is an interactive exhibit. It's designed to educate the public about the global refugee. And we were put in the situation of having to leave our home within 5 minutes. And they gave us, you selected cards of items that you took with you. You can only take 5 with you, from your clothes to food to water, your phone, etc. And at each point along the way, you had to give up one of them, where you were left with just one. You ended the simulation. And it was surprising for all of us as we were going through that the one hung on to was their phone, because this was their way of communicating back to their family. And so Doctors Without Borders, when they see a refugee camp, has, one of the things they learned they have to have are electrical plugs, abilities for people. So it was just very eye-opening. So I'll go ahead and let you watch this 1.5-minute YouTube video about the interactive, and that'll be it, and we'll go for questions. So if you could play the video, please.
We have 65 million people around the world displaced now, and that's such a huge number that it really just becomes an abstract concept. The real goal here is to put a face to this huge problem that we're seeing globally.
It's very interactive. We have 8 different stations, including a 360-degree video that shows you living situations and gives you profiles of people who've been displaced from their homes and our field workers around the world.
You think what's most important to you?
Imagine that you're one of these refugees forced from your home suddenly because of violence or any number of other reasons. This exhibit describes what that journey is like.
It's testimony from people who've actually lived these experiences, field workers who are telling their stories.
You feel it, like you actually get to feel it.
What you hear on the news is actually like only a fraction of what's really going on.
You get more of a connection when you're doing it hands-on versus just sitting and reading.
It's like something that will touch you and you'll be very, very moved by it. So it might change your life.
Before I leave, just is international organization. We've heard a lot about Doctors Without Borders and the good work that they do. There is also an organization called RAICES, R-A-I-C-E-S, a international organization that meets migrant populations. They're called RAICES. And if you are looking for opportunities to volunteer or volunteer opportunities in some way, get connected with meeting the needs of the refugee migrant population, these are 2 organizations that would address those. And thank you very much.
Yeah. How powerful Dr. Cantu. It pulls at my nursing experience, it pulls at my humanity, it pulls at, as a mother, as a wife, it pulls at everything. And I think it can be a little overwhelming too. I feel, how do we meet all of those needs in one nurse, regardless of your role or your practice setting? I think of my experience now. I work in a county hospital that we serve 22 counties and abroad. We often see people who are from various parts of the world who are in great need. And I feel of so much compassion, because I can only imagine, I can't understand because I've never been there, but I can only imagine what, when they're sharing, you can only take 5 things with you, and you're probably leaving. Nobody wants to leave their home just because they want to leave their home. There has to be something that propels them, to push them to say, we have to go. And I can only think as a mother and a wife to say, you know, when you were talking, Dr. Cantu, as women are catalysts for change, to uproot our family, our children, leave behind almost everything we know and love, to seek refuge and really safe haven for basic living needs and restart again. So talk about resilience, but I think you gave some really meaningful and just eye-opening in your presentation. So thank you so much, Dr. Cantu, for that. Yes. One of the things that we were looking at as far as just kind of taking a little bit deeper dive, as we know currently there are insufficient numbers of nurses, and we know nurses cover the broad spectrum from the bedside to the house to the hospital, whether it's a LVN, a registered nurse, advanced practice, a nurse leader. But how do we get to all of these underserved locations? Their movement is fluid. Sometimes it can be stagnated if they get stuck at a border or stuck somewhere. How can health systems, Dr. Cantu, government, educators, and payers overcome the deficits? We have a large number of deficits. And how do we increase the numbers, the types of distribution of the nursing workforce and the human capital needed, and improve in their knowledge and skills to fill the gaps related to socio-demographic and population factors? I know that was a lot of questions, Dr. Cantu, but I think when we're talking about population health, we're talking about being a competent and proficient global citizen. I think we have a lot of needs. How do we get there? Where do we start, I guess, is the first question.
There definitely are a lot of needs with all different populations that are coming into, again, not only the United States, but Germany, other places in Europe. I think certainly it would take a commitment from the leadership if you're talking about healthcare system. So it would something to affect the population is not going to be from the individual nurse. It would be that commitment coming from your executive leadership. So I think that's going to be important, is having that commitment there. And then that commitment would trickle down, if you will, to the nursing staff or nurses that work for the organization. I mean, we can just nurses in an encounter are impacting one or a family, one person or a family, but it requires an investment in resources, not only financial resources, but personnel, et cetera. And that commitment comes from your executive leadership, the politicians that you put into office. Those are the individuals, those are those structures that help develop this humble way of viewing migrant populations and taking care of our refugee populations. As you said, nobody really wants to leave their home. And so are we electing leaders? Are we working in an organization that has that empathy, that view of that the migrant population from that viewpoint? I think that's important, and for each individual nurse to understand what it is the perception of their leadership when it comes to this particular issue. And then we can also, from nurses, as we all belong to certain organizations, associations, and those associations can also lobby for and advocate for those changes that need to happen at the structural level as well. So we can do, nurses individually can work in a number of ways. Individually, certainly with the care that we provide, but also the lobbying and the advocating we can do to the leadership positions.
Absolutely.
Yes, thank you, Dr. Cantu. I have one question. Underfunding limits the ability of school and public health nurses to extend healthcare services and increase and create a bridge between healthcare and community health. In your opinion, how would adequate funding enable nurses to expand their reach and help improve population health and health equity?
The issue of nursing shortage, I think, has been as long as I've been a nurse, there's always been a nursing shortage. And the shortage can be answered by an investment in funds that help more students, more diverse students, get a nursing degree to go through nursing, because the more diversity we have in our profession, the more likely we are to provide care that is equitable. So I think it requires an investment in schools, community colleges, universities. So more opportunities for grants, more opportunities for scholarships, but also I think it also calls for schools to be much more flexible. I think our nursing students, our students are not the way when I went to college, you can by semester, you didn't work. Students are now working full time. They've got children. How flexible are nursing schools in meeting those needs so that we can get more nurses graduated? So we as schools need to become much more flexible, and to achieve our goal of equity, we need to look at our structure of how we're educating. And I think it's a time of change. It's a time of change right now, and schools need to address that need, that change.
Yeah. I think of my own experience, Dr. Cantu, having, I was a very young person, but still had to work full time and go to nursing school just to obtain my associates before I went back to school multiple times to get to where I am now. But I also think back of when you were talking earlier, it's not just the individual nurse having that one-on-one care. And I know I've seen discussion that one person's encounter can change the lives of 10,000 people in their lifetime. But I also think that it's time, when we're in the time of change right now, nurses need to feel educated, not just prepared, but equipped to be the nurse leaders at the policy table. We should be electing nurses, whether it's for a school board, it is for a hospital board, it is for city council, legislation, Congress. Wherever there is needs of the patient, there should be a nurse. And nurses have a unique perspective to bring that empathy, compassion, but also the science behind innovation and change. And so when we're talking about how do we meet the needs of the global humanitarian effort that's really in front of us, it's not just the United Nations, it's not just other countries. It starts with us making a concerted effort. Yes, we're a nurse, but what else can we do to help? And maybe that's at the policy table, wherever that policy table will lead. Sometimes nurses have opportunities to do advisory council work for their states, which can impact legislation that then trickle down into those policies that nurses are really required and asked to uphold in their state and their national duties. But we want to be mindful of time, but we had a viewer that just asked when you were talking, Dr. Cantu, about the WHO. They were remarking, why does the WHO not recommend testing for communicable diseases, especially in the pandemic? And when I was hearing you speak on that, I was thinking the WHO's perspective potentially was, let's get them the entire health assessment because there's not just physical need, but there's emotional and spiritual needs in addition to whatever potential communicable issues there may be. What are your thoughts on that, Dr. Cantu?
I think that certainly is part of it. And I think the WHO's perspective is not to put an additional barrier that the person may see as anxiety producing, because if I fail that test, does that mean I don't come in? Certainly, if someone that is positive for COVID, you want to find that out. You want to find that out to quarantine them. But I think the WHO's perspective is not making it a condition. And if they can to make it a condition and then therefore be a barrier for them coming into the country. Yes, you want to test for COVID. Yes, you want to put them in quarantine and get them vaccinated, definitely. But looking at it from the being a barrier viewpoint. Good question. Yeah.
I think
Yes.
of the Dr. Cantu, when you were just talking right now, I think of when people were going into Staten Island and they had to have that health check way back when. And I think of how burdensome and how anxiety provoking those families were, yes or no, and segregated and split, and kind of the fallout of what happened during that time period in that migration period. So thank you for that. Whoever asked that, thank you very much.
Yes, thank you, Erin, for those great questions, and Dr. Genthu for your presentation. I know that there are going to be more questions, and we'll be able to answer those after Dr. Harrison's presentation. But Dr. Harrison is equally as passionate as helping patients, and she's been doing it since she was a child, and we're so, and when I mean that is because she cared for her mother and assisted with her at an early age. And so we want to introduce you to Dr. Latricia Harrison in her presentation. And her focus today is going to be on diversity and inclusion in nursing, and how nurses can leverage and actively promote diversity within their teams and create an atmosphere of equity and inclusion. And so, Dr. Harrison, would you please start with your presentation? And of course, we will have questions, and some are sending them during the presentation. If we don't get to it, we will definitely address those after your presentation. So, Dr. Harrison, let's hear about diversity and inclusion, because it's so important for everyone, especially right now and all the time.
Absolutely. Thank you. You're absolutely correct. This is a time that we should be addressing diversity and inclusion. It is so important to talk about it as it relates to healthcare, as the patients' health disparities, as well as working with one another. So I'm excited to be here. So if we can pull up the presentation. So I am Dr. Latricia Harrison. As Sonia said, I worked with my mom, who was a nurse, all my life. So very passionate about nursing and very passionate about the change. But so glad today that we're having this discussion, because as a nurse, I've been a nurse for 27 years, been in healthcare for over 30 years. And there was a time when we didn't speak up or address diversity and inclusion. So now's the time to affect change. Next slide, please. So looking at how nurses can leverage and actively promote diversity within their teams and create an atmosphere of equity and inclusion. We have to start with self-evaluation. We have to look at our own personal implicit and explicit biases. If we don't identify within ourselves how we can change, then it doesn't allow us to promote diversity within our team. So we want to effect change. If we want to effect change in healthcare and surrounding racial equity and health disparities, we must identify our biases, and then we have to address those biases. So this is the time that we start to have those difficult conversations, identifying explicit biases, and those are the biases that you are aware of. You may not want to go to a certain unit and work with a certain population of patients or these particular nurses that are on that unit. Those are biases based upon whatever the reason that you may experience. Implicit biases are those biases that we are unaware of, things that have shaped us, who we are, things that may or may not actually correlate with some of our beliefs, but it's ingrained within us. So our biases are not bad, but they can be beneficial, they can be sometimes negative. So we do want to address those biases so that we can start to make the change in inclusion. Next slide.
Dr. Harrison, I have a question for you. How does one start the self-reflection process? Because I know that there's a lot of discussion right now, not just in nursing, but especially in the United States over the last 2 years. How does one start that implicit bias self-check-in, or is it best to do it with a colleague? What would you give advice for the nurses who are viewing in regards to that inventory? Or I guess it would be a needs assessment for our own selves before we can look outward.
Well, twofold. Very good question. I will start with hearing, because first we have to be able to speak up. If we are offended by something, most times we don't speak up. We just roll with it, and it's like, okay, I was offended. So, for instance, I'm an African American woman, obviously. And one of the things that I've encountered in my life is, if you notice my picture on the presentation, the promotion of this event, my hair is curly. Today, my hair is straight. We get a lot of questions like, can I touch your hair? Is that your hair? That's an implicit bias that someone may come up in a dress of African American woman, because they assume that my hair is not my hair. So they assume that I'm wearing a weave. And it may not be that they are intentionally trying to be offensive, but they have offended me. So now I have to assume responsibility for my emotions, and I have to address it and say that was offensive, and this is why. The offender have to be open to hear that they offended, and let's learn and see how we can address these issues. And then they have to start looking inward, and why do I feel this way? Why do I think that way? It doesn't mean that they're a bad person. It doesn't mean that they're a racist. It just means that they may have implicit bias that they're unaware of. So when I say we have to start looking within ourselves, we all have biases. We all have things like, oh, I don't want to go work on that unit because, you know, they all went to UT, you know, University of Texas, San Antonio, and I went to UT Austin or whatever. So I may have a bias because of whatever. I don't want to work with this certain population of people, but if I don't ever start to look within myself to see why do I feel these ways, I can never affect change. So I always say, like Michael Jackson says, start with the man in the mirror, look at what your likes and dislikes are, and then you can start addressing those things and start to make change.
Yeah, I think it's so important to look within ourselves instead of point the other finger at what is somebody else doing to me, versus we have to also look at ourselves as to what are we doing to others, right? It's how do we help somebody else's life be better? And it is our behaviors, our attitudes, our actions, whether it's meaning or not, sometimes we really have to take a look in that mirror to change our own selves, to be able to be the change that we want to see in the world. I think of sometimes too, this is a very sensitive topic. Sometimes people who are of Hispanic or Latin descent, we come in many shades and colors and from all over the world. And sometimes we can be said, we're too güerita, we're too white, or we're too
Or we look the same.
Or in, you know, some are blonde haired, blue eyes, or some are blonde or red or green eyes. And it's just, but it's not only how we look physically, but sometimes it's even, why can't you speak a certain language or dialect? Why can't you do XYZ? Why didn't you know this tradition? There's a lot. It's a melting pot right now. And so I think right now that's another unspoken that I think oftentimes we don't address because it's uncomfortable for the person who's experiencing it. What is my family and friends going to say? What is my colleagues going to say? And it's those perceptions too. But thank you, Dr. Harrison. I think that's a great first step for us.
We can go to this video, and this video is going to address just what you were saying, Erin, on looking at different situations and how biases or microaggressions take place in the work setting. This video was taken from YouTube, and it just kind of encompasses in the workplace environment overall. But once you take a look at it and see, you can kind of get an idea on some of those microaggressions and biases that we encounter and how it makes a person feel. This video is about 2 minutes or so. So if you want to take a look at it, we can go ahead and start the video, and then we'll come back and answer more questions. the video is very powerful. What do you all think?
I was just thinking, Dr. Harrison, how nurses, especially over the last almost 2 years, how we've had to shift, adjust things on the fly within moments to seconds. We've had coworkers we've never known. We've had illness we've never known, meds we've never known. But then we also have to deal with the same that we were talking about earlier, is these biases. How many times have our coworkers had emotional and spiritual and just physical exhaustion to the point of perhaps anxiety, depression, sometimes even suicidal ideation, but they were too scared to reach out? Look at the numbers of suicide attempts that have gone up within our healthcare, our colleagues, even our nursing. I think of not just the social challenges that we've all been seeing and being a part of. How do we be that one to step up and change? I think that's the number one thing, is we have to take a stand, because inaction is a voice and an action in and of itself by not saying something. So I think as nurses, being the most trusted profession over the last 19 years, I believe, we have an obligation and a duty not only to ourselves, our colleagues, our community, and our global health. Talk about being a global citizen. We've got to be the ones to take the stance of saying this is not okay, for whatever that reason would be, because there are so many different biases that are going on right now, and systemic cultures that need to be changed. And it takes not just one person, but it takes that one person to take a stand that is courageous and brave to say, let's talk about this. We can have a civil conversation if the other party is willing to do that. And I think the future of Nursing 2030 is addressing some major systemic changes that need to happen, not only within our nursing family, but also existential and external. And how do we work together to be that one voice that unites all of the nurses to be that change? So it is powerful.
It's very powerful. And I also think that, you have a lot of organizations and individuals that say they want the diversity and inclusion. And are they really inviting that, or are they just vocalizing that because it's something that's trendy, or it's something that's popular, or it's something on everyone's strategic plan for their facility or organization to address with their employees? And so actually doing something about it and talking about it is important. And in leading other nurses and nursing students, when leading and managing effective teams, how does that, entail this diversity and inclusion for leaders like you and for new students that are coming into the industry, which leads me to my next slide. Why is it important to build and maintain trusting relationships among team members, communicating effectively and supporting each team member? Dr. Harrison, can you elaborate on that?
Absolutely. Dr. Cantu alluded earlier about trusting relationships. And as Erin even said, about how the nursing profession is the most trusted profession. But if we don't trust my coworker because they make me feel small, or they are intimidating, or as the old saying goes, the nursing eats their young. If these people if we don't make one another feel comfortable and welcoming, you're not going to have a trusting relationship. That lack of trust between coworkers, doctors, nurses, ancillary staff, if it's not there, it affects the patients, it affects the work environment. So we have to be able to, again, listen. We have to speak up. We don't have to be rude and disrespectful, but if my feelings are hurt, I have to be able to address it, and the person who hurt my feelings should be able to hear it. We should be able to have a conversation surrounding it. As you alluded to, Sonia, about diversity and inclusion, leadership has to not only be trendy with the topic and say, okay, we're going to put a DNI officer on staff and we check that off the box, and nobody is actually implementing the change. I got into this because I had to do some self-reflecting and I had to take a stance. During the George Floyd situation and everything that was coming out of there, you saw so many nurses, healthcare providers, doctors, physicians, people speaking their implicit and explicit biases. And there were so many debates. I've been in education for 20 years. And one of my former nursing students, I used to teach LVN students and RN students. And one of my former RN students called me and he was like, and he's Filipino. And he was like, I just need to understand. I'm not understanding it. He was having an internal fight with coworkers and family members regarding his stance. And people were expecting a stance. So then that was a mistrust and a breakdown in the relationship of his family and within the coworkers that he was working with, friends that he had built relationships. And, you know, and I just talked with him and I was explaining to him just what it is. Just because you're Black doesn't mean that you pick a side. Okay, I'm going to choose this, I'm going to choose that. You have to stand for what's right. If you're a non-African American person and you see someone do something that's offensive to someone else, say something, see something, say something, speak up. You know, it doesn't mean that we have to, just because we're two Black people doesn't mean that I have to be supportive of the Black person if the Black person was out of order, if they were wrong, if they were offensive. Just because you may be Hispanic or you may be white doesn't mean that you have to support what people who look like you are doing, because you have to stand for what's right. And that's always been my standpoint. I stand for what's right. So that translates into my relationships. I'm going to hold you accountable, and we have to hold one another accountable to even develop those relationships, because if there's no trust, there's no relationship.
I think of when I engage with somebody and I can tell in my own mind, I am not okay with what just happened. I really have to really pause and think, is it kind? Is it necessary? What are the risk benefits alternatives of what I'm going to share with this person? Or maybe it needs to happen on another date so I can self-reflect and be objective and not so emotionally charged with it. I think of also some of the challenges that our different cultures have had, whether it's been with the Jewish community, whether it's been with Asian population. It doesn't seem to have a rhyme or reason. I think I'm shocked at the level of hatred and anger and just how could somebody else do that to another human? You know, in that video we saw, we are all human. No matter what you look like, you are human. And how, as nurses, because we know not just the physical, we also are trained in holistic care, emotional, spiritual, that patient, that family, that caregiver, that picture of what's happening with that patient. And I think if we don't start to talk about this topic as a whole, as a nursing community, and then start to be at the table for policy leaders that are making changes, we are the change agents as nurses to make sure that diversity, inclusivity, equality is there, but also that humanity is there. That human side is kept, not just in black and white policies in a checkbox. And so that's why I think bravo for the future of Nursing 2030 to start this ongoing discussion. But I want to say thank you to Nurses Care Hub for actually allowing a platform for open discussion so we can have a pretty free and safe zone to discuss this topic.
Absolutely. The Nursing 2030 report talks about this in great detail. And so a lot of outcomes that are needed for sure. And so thank you for that, Erin. I really appreciate that. And Dr. Harrison, as an advocate, what organizational policies and structures support nurses and promote equity in your clinic or university? Can you share with our audience some of that information that we're maybe they don't know, they've never seen, maybe they can follow your model?
Well, what I would say is a lot of the organizations and the facilities that I affiliate with are now have implemented diversity and inclusion training. So I identified that I work for the University of Texas, the two Galveston Medical Branch, as well as the University of Texas Houston Health Science Center. And one of the things that they have done, which I was so excited to see, is that as you go through your annual training, you're actually going through training with diversity and inclusion as well. So now they're talking about it, they're teaching you about the biases, and they're implementing these policies as mandatory annually for all the staff. Everyone has to go through this training. So it educates you on what is a bias, because a lot of times we don't even identify that we have a bias. So being able to first understand what it is, what the terms mean, because you have so many terms that are out here now, and it's like, okay, well, what is this or what is that? I've never heard of it, but you've experienced it. You just didn't know it had a title. So now that they're implementing these things, and then just being that change agent, having a seat at the table, speaking up, asking questions, you can't be afraid. For so many years, more seasoned nurses would not speak up because you may have been a single parent and you needed your job, you needed your income, you were afraid that there were going to be repercussions if you spoke up and said something, if you challenged being passed over for a position. So you just kind of held back and just tucked your tail and went on. So now it's time to come to the table again, listening and speaking up and being aware, being educated so that you can go in and help to affect change within the organization.
Right. No, that is absolutely, and you and I talked real briefly yesterday, and some people feel intimidated to share their voice, right? And they're scared they're going to lose their job or they have to provide for their family, and so it can be intimidating for some. And we are at 2:00. It goes by super fast, and we're going to go over because we still have some questions that I think that our viewers would want to hear from you, Dr. Harrison. And I know Dr. Bettis has some questions. But if you don't mind, we're going to go over just a little bit past 2:00. And if those who are registered have questions, please let us know at the end. But I think we're going to take it another maybe 10 or 15 minutes if you all don't mind. Dr. Harrison, in the Future Nursing 2030 report, they talk about cultural taxation, and it refers to the phenomenon whereby faculty who are individuals of color are asked routinely to take on extra uncompensated work to address a lack of diversity in their institutions. What are your thoughts on cultural taxation?
This was a great question. Cultural taxation is a new term, right? Didn't know what it was, had to go research it. Lived cultural taxation. As I shared, I was a nursing educator for many years. And one of the situations that I was in, I was the only person of color in the nursing department. And work with the people. It became, when I didn't agree with something that they were doing, I became the person that was aggressive. No one wanted to work with me. You know, all of those negative labels. The dean met with me, and one of the things that he told me was, you need to stir the pot. You need to show them what you're capable of doing. So I'm going to give you an extra assignment to go out and do so you can prove to your coworkers, your team members who have the exact same degree as you, or your degree was higher, my degree was higher, to prove to them what I was capable of doing. I've been there 6-7 years already. So it wasn't anything new, but because there was some tension and a disagreement, all of these things surrounding me came out. Well, I didn't know at the time. I just took it, rolled with it. I was offended. I was frustrated. I did not speak up. I just did the assignment, came back and I had to prove my point. One of the things with cultural taxations as a person of color and being in that situation, you always feel like you have to carry the weight of the world on your shoulders. You're always having to be that person to explain the culture, to justify, to not speak up. I mean, you're always having to prove that our skills, we have to prove our scholarship. We're having to prove that we are capable of performing the job. We are not allowed to be mediocre. It's not an option for us. We're constantly having to prove ourselves. And now that there's a label here, now that people can see, hey, this is what's going on. Again, going back and doing that evaluation, having a discussion. I wish now I would have known what I know now back then, because then I could have spoken up and not been offended. I just quit. I just left the job. I actually got out of education shortly after that, just because it was just too much. And I was tired of being the only person of color on the staff, and having to go through these constant battles. But I would tell someone today, speak up, take a stance, educate, and be that change agent that we need, because this is the time to make those changes.
I think of Dr. Harrison. I tell people when I started in palliative care and I had just become a nurse practitioner, I started in an organization where I was female, I had a ponytail, I was palliative care, and I was a nurse practitioner. I had 3 strikes against me just walking in the door. And how I was told from the get-go, you have to do everything that much better, that much more efficient, that you have to bend over backwards even that much more than even a physician would, to prove that you can not only be a quality clinician, but you are a business where we can refer to you and you'll take care of the business that's being sent to you. So talk about working when the moon's out and coming home when the moon's out. I think the longest stint I did, Dr. Harrison, was about 4 months without one day off. And I was going in, and talk about having your own health suffer, your family suffer. But I think oftentimes, regardless of what the situation is, when people are told you have to do, the bar is so much higher because XYZ, that should be a red flag for people to listen. Is this new title that we now know is cultural taxation? And really reflect, and that way you can have a dialogue so you're not put in a unsafe, I think, whether it's unsafe for your practice, unsafe for your health, unsafe for your family, your group. I think now that we're learning more and we're having something tangible to talk about, to say, hey, here's the evidence, let's talk about this. I think hopefully for our future that's coming up, because we want to affect change not just for now, but for our future nursing colleagues, so they don't have to go through a lot of what a lot of nurses have had to experience.
Right. No, absolutely. Like I said, the Future of Nursing report, they have so many goals that they need to accomplish in the next decade, and it's going to start with the next generation and with you all as leaders and us as leaders to get them and get the industry somewhat in a starting position. And so that leads me to the next question. Racism, structural and cultural, and discrimination, sexual orientation and gender, place, rural and urban, are deeply entrenched in the United States society and its institutions, and in the nursing profession is no exception. And so the next slide, nurse leaders can play an important role in acknowledging the history of racism within the profession. And Dr. Harrison, we have this question: if nurses are to take on this role, why will it be essential to build a more diverse nursing workforce and support nurses of diverse backgrounds in pursuing leadership roles?
I love this question because, again, when we go back and look at the history of nursing, when I first started as a unit secretary, people who looked like me were not in positions of leadership. If they were, you may have had one person of color who worked 11 to 7. Everyone else was on the day shift. And now it's time to be able to start with the nursing schools. As Dr. Cantu talked about earlier, you have to bring in the change in the educational system. We have to start teaching our nursing students about diversity and inclusion. And we need to start prepping them for leadership roles. We have to start mentoring them, teaching them, putting them in positions that are going to propel them in the profession, because that's our future. We're standing on the shoulders of many, many great nurses, many people who have come in and brought about a change in healthcare. So it's not all bad, but where we are now is pivoting, and it's time now to embrace the change and to build up and nurture our nurses that are coming behind us in whatever role. And it can't be, I'm superior and you're down here. So because I'm a nurse, I'm a RN, I'm better than LVN or the nurse aide, so I don't have to pull the trash, or I haven't worked in the hospital in 20 years, so I don't know what they do. So, but they don't have to do those things that in a long time ago may have been looked or frowned upon if you were a registered nurse. So now I feel like it's time to start with education, start in the school systems and changing the thought process. And then when we are in these positions, start to have preceptorship or fellowships within the nursing profession so that we can train and build up leaders that's coming behind us.
I think that, Dr. Harrison, is the key to essentially growing our babes from undergraduate and then graduate and then postgraduate. We automatically have this taught, and it's instinct. It's not an add-on. It is a value add that is brought up, and it's a culture that you have learned from day one of your nursing experience, whether you're new to nursing or this is your second career or you're progressing in nursing. I also think of, across the nursing roles, regardless of our color, regardless of our sexual orientation, regardless of our religious or faith background, we all have to work together, because to change the world, to make a better impact and raise those health outcomes to be more positive. I think of the commonwealthfund.org that we consistently reference, especially in Texas. For our viewers, if you go there, you can click on your state, and they always do a report card on a number of various health outcomes. And Texas is generally in the very bottom, and I'm talking very bottom, usually between the 45th and the 50th out of 50 states for healthcare outcomes, no matter what the outcome is. And I think as nurses, we have the opportunity now to change ourselves to better help change the world and our ripple legacy. And when we're looking at how do we change, we look at now it's not just going to school to do a nurse or punching in and punching out to be doing nursing as a profession. It's, oftentimes I will tell people it's no longer about renting your profession. How do you own your profession? And I think this change to help others right now, and especially meeting the needs for our new nurses who will be caring for us, that is the key. We have to be willing to get out of our comfort zone and take more time and effort and resources to help these new people and help our colleagues. So in the next, say, 2040, 2050 report, we've moved the needle forward for a better and not backslided because we didn't want to take the steps and the resources and the time when we could have made that change happen.
Right. Nicely said. Thank you. Thank you so much. Dr. Harrison, you are a change agent. We are change agents today, and all have been. And so that leads me to my last question. As a leader in your clinic, please share how you implement policies and systems that promote equity and address racism and discrimination and bias in the organization. If you can share that with us, I think we would like to hear a little bit about that.
We have to, I can't say it enough, accountability. We have to hold people accountable. I own and operate my own practice, so I can implement whatever policy I want to. That's the benefit of being an entrepreneur. However, I do have patients who I work for. They are who I service. And I had an elderly gentleman. He hasn't seen me since this exchange. And what he did was every time he would call the office, he was very condescending to my staff. And they told me about it. And what he would say is, you people this, you people that, you people, because he wasn't getting his way. Well, I politely asked him not to say that it was very condescending, it was offensive, and if he would please not address us as you people. Well, he was offended. He was, well, why should I do that? Why? I mean, you know what I mean, so, and I just told him politely again. So I fired him as a patient because he did not want to hear the offense that came along with it. So what the tolerance level is that we will not be rude. We will not be offensive to the patients, and we are not going to allow the patients to be offensive to us. So I held them accountable, and we hold every patient accountable because they hold us accountable. So we have to ensure that we are trained, educated, and that we're not being disrespectful. So we can't get what we don't give. So those are the things that I do. So accountability for people who are working in an institution, a hospital, a university, a clinic setting, wherever, you have to hold the leadership accountable for what they're implementing, but you also have to take a stance. And then again, you have to go back and look at your own individual biases, and so that you can ensure that you are not assuming or missing, or you want to do some self-evaluation so that you can be better, so that you can help the people around you be better.
I just had that conversation, Dr. Harrison, with a nurse leader this week where we were talking about a couple months ago, my experience with a patient who was in the hospital for COVID. He was not in the ICU, but he was throwing things at myself and the nurses and cursing at us, and how we quickly needed to de-escalate and make him, yes, we're here to help you, but we did hold him accountable for his actions, so we're not subject to verbal or physical abuse. And this nurse leader this week just told me, Dr. Harrison, she goes, there was a healthcare worker on the phone that was verbally abusive to one of the nurses, and it got escalated to me. And she said, this is the first time in my career that I felt empowered to not accept verbal abuse. And I thought, wow, because this person has been in nursing for over 25 years. And I'm thinking, if this is the first time this person has felt empowered as a nurse leader not to take verbal abuse, that's another culture change that we need to have within nursing, to know we've got to put not only the patient safety first, but our safety first. And we are not subject to verbal abuse or physical abuse, that we've got to hold people accountable in a kind and professional way, but not allow for this to be tolerated through leadership as it's just part of the nursing job, when it's not just part. We have got to start to teach our community that our nurses are there to help, and we are not subject, and you will be held accountable at this time if your actions are not safe and professional for our nursing colleagues.
I'm glad that you...
I'm glad that you said that. Yeah, go ahead. That's fine. I was just agreeing. I think that was great. Mm-hmm.
No, I think that was great, because in our next session with Nurses Unite, providing care for a changing America, because that's exactly what this is where we're going to talk a little bit about the nurse stress and trying to prevent nurse stress and supporting nurses. And so that's a great ending to this conversation, because we want to keep going with this conversation, because there's more. There's more and more, and you read more, and nurses need more. And so I think that building the trust and having change agents like yourself, Dr. Harrison, and Dr. Cantu, and Dr. Bettis, and And in getting rid of those biases is a start. And so we appreciate Dr. Harrison and Dr. Cantu for all that you have shared with us today. And I know that our registrants also appreciate and respect all of the topics that we've shared today. Before we close, I'm going to open it up to if you all have any questions. But for those who are on, if you haven't joined Nurses Community, if you want to connect with Dr. Harrison or Dr. Cantu or Dr. Perez or myself, we are in the Nurses Community, and you can engage and share an email within the community of Nurses Care Hub, where it's a place just for you, just for nurses, and you can ask any questions that you want there. Before I close, Dr. Bettis, do you have anything you want to share?
I just want to say thank you to Dr. Harrison and Dr. Cantu for taking time out of their busy schedules and their practices to give us at least an hour, maybe an hour and a half now of really insightful but really personal, pulling at your heartstrings topics that are huge topics with multiple layers. But I feel confident after talking with them that our viewers have some tangible steps on how to make the world a better place and be a better global citizen, but also, taking a look in the mirror, looking at ourselves, listening to others, and moving forward. And so I'm so appreciative to Dr. Cantu and Dr. Harrison, and thank you to Nurses Care Hub for allowing us to have this platform and this time. And I look forward to the future as we dive in a little bit deeper. I just want to make sure our viewers know that nursescarehub.com. Make sure you can join as a membership. We're happy to connect with you, and that way this conversation continues. I think the topics from Dr. Harrison and Dr. Cantu, this is not the one and done. It will only continue to evolve over time and in the near future. So please make sure you join us January 9th, and make sure you get that membership in at nursescarehub.com.
And membership is free, so we're not charging for membership. So please become a member today.